thank you. It's really a pleasure to be here. And I can sometimes drone on about pancreas cancer too long, so I trust that in 30 minutes someone will bring a hook out and just eliminate me. That probably is the best thing to do. So Dr. Cherniak and I shared a couple patients together. I think he probably got to know my administrative assistant, Wendy, a little bit better than he got to know me. But it was really a special honor for me to have worked with him in the venue that we did. A wonderful, wonderful man, and clearly a dedicated and caring physician. So it's a special treat for me to be here today in his honor. Well, with pancreas cancer, whether it be a pancreatic neuroendocrine tumor, as you can see on the left, or pancreatic adenocarcinoma on the right, we're in a completely different era now than we were 5 and 10 years ago. Tremendous amount of work going on. I think Dr. Clavian alluded to a lot of that. With respect to pancreatic adenocarcinoma, one of the challenges with trial development is that we now have much more effective systemic therapies. Of course, they come with greater toxicity, fulferinox, gemabraxane, to some degree GTX, etc. What we've been working on in Wisconsin over the past 3 years has been molecular-based therapy based upon our ability to genetically profile a tumor on an EUS-guided FNA biopsy. So the tumor is profiled at a molecular level, and then the chemotherapy is tailored to the patient, given both before and after surgery. And I think where we're going over the next year clearly is in the area of immunotherapy, capitalizing on the developments made in melanoma, renal cell, with immune checkpoint blockade. We're bringing that into pancreatic cancer, where historically the tumor microenvironment has not been friendly. There has not been T cells present, T cell activation, etc., but that clearly all is changing. So really for the first time, I think the next decade in pancreatic cancer management will be absolutely fascinating. And for those of you who are interested in cancer and haven't yet picked a field, you absolutely know where I stand, and we would love to have you come to Milwaukee and spend some time with us in our pancreas program. This is from the Pancreatic Cancer Action Network, and as you know, pancreas cancer affects good people. In the overwhelming majority of patients, at least 80%, there is no antecedent event. It's not related to lifestyle, tobacco use, anything else. If you saw patients with me on a Tuesday, which is my typical day in the outpatient cancer center, you would be struck that the one unifying factor, there's probably actually a significant p-value associated with that, is that these are all lovely, nice people who have led wonderful lives. And because of that, because we don't have a technique for early diagnosis, and it's not related to any lifestyle event, this is what is predicted in the future. That pancreas cancer will probably be the second leading cause of adult cancer death in the future. This is a paper that probably shouldn't have been published, but for those of you who work with residents and fellows, you should review the papers that come across your desk, because every now and then something will scoot through your desk and all of a sudden it'll get published, and it may be a tad embarrassing. So this is the experience at Memorial Hospital, and you know that I was at the Cancer Center in Texas for a long time, and part of our contract was that we could never say anything nice about the Cancer Center in New York. We had to sign that every year for when we re-upped. But in any event, obviously a joke. You can see this is the experience with surgery for pancreatic cancer at Memorial Hospital in New York. Absolutely no progress. And I think one of the things that distinguishes the surgical oncologist, and I noticed that Charles Balch was here 2 years ago, and hopefully you had time to mine his great history of philosophy. But I know that one of the things that he would say defines a surgical oncologist is a commitment to the patient of today as well as the patient of tomorrow. If you're not advancing the field so that 5 and 10 years from now we will be treating these patients differently, then you're probably not fulfilling your responsibility as a surgical oncologist. And you can see here no difference in survival in patients who got operated on for pancreatic cancer over multiple decades. So if you have a patient who you see who has pancreatic cancer, and they simply get an operation, and then outside of a clinical trial adjuvant therapy, you may be helping that patient, certainly we hope you are, but you are not advancing the field, you're not helping the patient of tomorrow, and that's something really to think about. As Dr. Clavian mentioned, I presented some work that I had done in Houston when I was a visiting professor at Duke in the mid-90s, and these are a series of clinical trials that I was involved in when I was at MD Anderson. The first I wrote as a fellow in 1988. And what he didn't mention is when I finished the talk, I forget who it was, but someone, it wasn't Dr. Savastan, stood up and said, well, you know, Doug, that was a nice talk, but that's just a bunch of garbage. I mean, that's the craziest thing I've ever heard, that you're giving chemotherapy with or without some radiation therapy prior to surgery. You should just be operating on all those patients. And it's fascinating how the field has moved. Granted, it's taken quite a while to do that. I just wanted to plant one little seed in your mind before because it's basically in my genome to have to say a little bit about treatment sequencing, even though I'm supposed to be talking about blood vessels, but I can't get away from it. You'll have to excuse me. So this is a paper that we published in JCO in 2008. So you can see this was 86 patients treated with neoadjuvant therapy prior to surgery. And the neoadjuvant therapy very effectively separated those patients with a good outcome, i.e. the 64 patients, from those patients with a poor outcome. So after 6 weeks of therapy, it doesn't really matter what the therapy was, the patients were restaged, brought to the operating room, and patients clearly fell out with this survival curve. At restaging, they had liver metastases that weren't previously present, or at the surgery, they had peritoneal disease. But you can see that that induction therapy was very effective in segregating the population into those likely to benefit from surgery and those likely not to benefit from surgery. And you avoided a big operation in patients where there would not be a return on investment. Obviously, as the operation gets bigger, the compelling need to have a better outcome after surgery is clearly obvious. And you can see really for the first time a median survival of patients who completed all therapy to include surgery was approaching 3 years, something previously not seen. So this is data from the Medical College of Wisconsin. Since I've been there, this is provided by my partner, Susan Tsai. Susan completed the fellowship at Johns Hopkins. So you can see that we're extremely open-minded. I even hired a faculty member who had been trained at Hopkins. Just a little joke. And you can see this is all patients now. So this is roughly 200, 220 patients. So not a huge sample size, but a reasonable sample size over the past 4 years. And as you would expect, here we have in green, and maybe we can turn the lights down a little because after this it's all going to be intraoperative photos. In green is Whipple plus adjuvant therapy, and as you would expect, the neoadjuvant patients were divided into those who completed all treatment to include surgery and those patients who did not receive surgery, i.e. they progressed during neoadjuvant therapy. So this is pretty much what you would expect, right? So if I was presenting this to a fairly unfriendly audience, which is usually where I'm asked to speak about neoadjuvant therapy, they would say, that's not fair. You can't separate those two lines. You can't separate the neoadjuvant patients into those who completed all treatment and those who didn't, right? That's completely unfair. You have to show it like this. Right? Is everyone with me? You have to show neoadjuvant plus Whipple, Whipple plus adjuvant therapy, and therefore these two groups are comparable. Right? Does anyone disagree? Are we missing any patients? Are we missing? We have everyone. So patients walk through the door. They have a little attractive yellow hue to their sclera, and they have a mass in the pancreatic head with bile duct obstruction. They'll either get Whipple plus adjuvant therapy, or they'll get neoadjuvant therapy, and they're all included on this slide, right? Probably not. That's not correct, because remember, this slide assumes now that in the Whipple plus adjuvant therapy arm, everyone was resected. And even if you're the greatest surgeon in the whole world, as Dr. Clavian mentioned, you will bring an occasional patient to the operating room who will have peritoneal disease. So the resectability rate at the time of surgery in most high-volume centers is in the range of 80%. And that's including patients who get an endotracheal tube. Okay? Most of us laparoscope patients, and you can argue about that, but in any event, if you take 100 patients with resectable to borderline resectable pancreas cancer to the operating room, you're never going to resect all of them, regardless of the local disease issue, because some of those patients will have radiographically occult liver or peritoneal metastases. So these two graphs are not the same, whereas when you start the patient on neoadjuvant therapy, they don't have a laparoscopy. So this graph is showing 100% of the patients who started out on neoadjuvant therapy, some of whom got surgery, and it's showing about 80% of the patients who were brought to the operating room for a potentially curative Whipple procedure and had their Whipple done. Okay? If you then add in the patients in whom we planned a surgery-first strategy, but their tumor was not removed, there they are. So it's fascinating. Two identical groups of patients, yet the survival is different solely on the basis of treatment sequencing. And one of the things we know about pancreas cancer is patients die with low tumor burdens. We don't know what they die of. The immune response to pancreas cancer is fascinating. So our micrometastatic disease deposits actually being effectively treated in patients who have not experienced the immune suppressive effect of surgery that would otherwise not be effective. Something really to think about that we're pursuing further. So I'm going to focus now my last 15-20 minutes on what I was asked to talk about, and this has all been published. I just wanted to show you a few things. Number one, our last year's fellow, Charles Pilgrim, was from Melbourne, Australia, and we would be thrilled to have anyone be interested in our HPB fellowship program from Israel. So this is where I've spent a fair part of my life, and I still find it fascinating, and that's the mesenteric vascular system. Portal vein, splenic vein, SMV, ileal branch, jejunal branch, the SMA. Remember, the inferior mesenteric vein may enter into the splenic or the SMV. Do the lights come down at all in the room? Only because it may be a little hard to see some of my slides. And it was actually Dr. Fortner many years ago who first said that, you know, when you do this operation, you should take out the entire portal splenic confluence as so-called regional pancreatectomy. And in fact, when that was done, it was reported that there would never be a problem, that you could always divide the splenic vein at will. And obviously that does two things when you divide the splenic vein. It gives you access to the SMA, which is very important for a difficult resection, and it also gives you increased length of the portal and the SMV so you can put them back together again. The problem is in some patients they will get sinestral portal hypertension. And we know that in patients whose IMV enters the splenic vein, they'll get retrograde flow down the IMV and their splenic decompression will probably be adequate. However, if the IMV enters the SMV, that probably will not be the case. And whenever in the United States I talk about this, typically Dr. Strasberg gets up and tells me I'm crazy and that you can divide the splenic vein at will anytime. And I can never say anything bad about Dr. Strasberg because he has taken care of a couple complications of my patients. And that's always a humbling point. Whenever you have a patient from out of town who returns to their hometown and another surgeon has to take care of your complication. But in any event, I'm going to show you in case in point where sinestral portal hypertension really exists. So this is a patient that we operated on who had the IMV entering the SMV. We had to take out the splenic portal confluence. So what we did was we divided the splenic vein and brought it right down into the left renal vein. The operation described at Emory many years ago for renovascular hypertension, the so-called distal splenorenal shunt. In this case, the left gastric or coronary vein is intact, and by dividing the splenic vein, we had adequate, sorry about that, we had adequate distance to bring the portal vein directly into the SMV. And then just a close-up of the splenic vein going into the left renal vein, again preventing left-sided or sinestral portal hypertension. This is a patient where that whole physiologic process, I think, is proven. 77-year-old woman treated with GTX had a great response. GTX was developed at Columbia, where this woman was treated. Her daughter is a radiologist there. And there was some debate as to whether her tumor could be technically removed, and we were asked to weigh in on this. This just shows the waterfall plot of the combination of gemcitabine, Taxotere, and CAPE in pancreas cancer. She received both clinical benefit, her CT imaging was better, and her 19.9 had declined. So we basically evaluate three things after neoadjuvant therapy. Is the patient clinically better? Is their radiographic imaging the same or better? And if they're a 19.9 or a CEA producer, are those numbers down? We never combine a high-risk operation with a high-risk oncologic situation or a poor-risk patient. The results of surgery for this disease are so modest that really you can't justify a perioperative mortality. So we're very careful about who we operate on. So here we are in the operating room now. So we have divided her splenic vein. You can see here the staple line because her IMV entered directly into the splenic vein. That opens up the entire retroperitoneum, so we could separate the tumor from the artery quite easily, common hepatic, and the tumor is now sitting there encasing her SMV portal vein confluence. And here she is put back together, SMV sewn to portal vein. SMA, we have a huge IPDA. This patient had median arcuate ligament compression of the celiac axis, which we relieved, and that's the reason why the IPDA was so large. So the splenic vein was simply divided. It was not hooked back up to anything because the IMV, the inferior mesenteric vein, drained the splenic vein and decompressed, theoretically, the left side. Well, she then developed gastrointestinal hemorrhage, had an endoscopy, and what do you think the endoscopy showed? Showed nothing. Remember, gastroesophageal varices can be very hard to see. So she's in New York. Her gastroenterologist called me up and said, you know, she's had a couple GI hemorrhages, melanotic stool. We scoped her, we don't see anything. And I said, that IMV is either out, there has either been fibrosis, i.e. or tumor recurrence, more likely, knocking out the IMV. She now has sinestral portal hypertension. So she came back, CT scan showed that the IMV splenic vein junction was out. She had developed left-sided portal hypertension. We embolized her splenic artery, and here we are now. Embolized her splenic artery in September 12, and here's an email from her daughter just a couple weeks ago. And this woman is clinically well. We have decreased the inflow to the left side, and she's actually doing fine. This is a different patient, but just shows you again, this is after the tumor has been removed. So this is a nicer view of the IMV splenic junction, completely intact, SMA, common hepatic artery, SMV portal vein. Again, a primary anastomosis because the splenic vein has been divided, giving you increased length to hook the SMV up to the portal vein. So in this patient, we didn't do a distal splenorenal shunt. This is a patient treated at Carmanos Cancer Center in Detroit. Young woman, again, these are all healthy patients I'm presenting to you who have had these big operations. And you can see borderline resectable to most people would say locally advanced cancer, distal cancer. Here's the artery. We have a very poor distal target. She gets FOLFIRINOX followed by gem radiation. And look at this. These are responses that we just didn't see in the past. Now look at the quality of that superior mesenteric vein. Profoundly different than it used to be. And I think being a surgical oncologist in the next 5 to 10 years is going to be a really hard job. The results we're getting with more effective systemic therapies are then presenting patients who would otherwise previously never be considered for surgery. So the medical oncologist does the best he or she can the patient is still standing, not only still standing, but looks well. And so what do? They call you up and say, should we take out the primary tumor? It will be a challenging field, because I would submit to you that a patient, especially if they're in their late 70s or 80s, after 6, 8, 10 cycles of FOLFIRINOX may not be the same patient that they were physiologically before all that systemic therapy. But in any event, young woman, so here's her situation. Now, her tumor was encasing the SMV inferior to the splenic vein confluence. So we certainly didn't want to divide the splenic vein, but we clearly had to have complete exposure to the artery in order to do an adequate arterial dissection. We couldn't have that splenic vein in the way, so we kind of invented this operation. We did a temporary mesocaval shunt, so we sewed her SMV. In this case, we used internal jugular vein as a conduit to her IVC, divided her splenic vein, and this just shows in the operating room with the tumor in place, the internal jugular vein going from SMV down to inferior vena cava, Ramel tourniquet around her superior mesenteric artery, and the tumor is now out. The SMA is skeletonized. The SMV has been divided. We have splenic portal confluence intact, and we have SMV to IVC. So normally, what we would have done is simply reconnect this together. The problem, of course, you have is that that is right in harm's way, if you will, a long venous interposition graft sitting right beneath your pancreatic ojejunostomy. So what we did in this particular case is we simply left her mesocaval shunt intact. We wrapped her artery because we had denuded a little area of adventitia. We wrapped that with saphenous vein, and we just left it like this. And she actually has done quite well. Because of the extent of deinnervation of her small bowel, weight loss and rapid gastrointestinal transit have been a problem for about the first 9 months after surgery. She's now about 1.5 years in doing well. And this just shows a second patient where we did a primary anastomosis of the SMV to the inferior vena cava, and you can see how it widely opens the whole root of mesentery and really gives you unimpeded access to the superior mesenteric artery. I think if you can see the SMA, an injury is unlikely to occur. Arterial injuries at the time of a complicated Whipple procedure usually occur because of lack of exposure, not due to any other reason. And this, in contrast, shows a patient who had a total pancreatectomy with a long interposition graft needed. And you can see that this interposition graft is prone to anything that may occur in this area. So if you have a fluid collection, if you have a seroma, if you have a leak from the pancreatic ojejunostomy, that interposition graft is certainly in harm's way, thereby prompting us to at least think about, in very carefully selected good risk patients, the opportunity of leaving them with a mesocaval shunt. I wanted to, in my last couple minutes, present now a tumor to the left of the artery, and I may not have time to get through everything. But this is one of the first patients who was treated on the combination of gemcitabine and nab-paclitaxel, or Abraxane, developed by Celgene in cooperation with Dan Von Hoff at TGen in Arizona. And this woman comes from Arizona, was on the original phase 2 trial of Abraxane. And you can see the waterfall plot here. And this is her CT scan. Again, a very young woman. That's the reason why surgery was being entertained. And you can see a big, nasty tumor to the left of the celiac axis. Big tumor here. And she was given Abraxane for almost a year. And look at this response. Just incredible. I mean, this is stuff that you never saw 10 years ago. Some of these responses with Abraxane, with FOLFIRINOX, and I think as we move further into the addition of immunotherapy, they'll even be more dramatic. So this would traditionally be handled with the so-called Appleby procedure, where the celiac artery is removed and retrograde flow is taken through the gastroduodenal artery from the SMA to supply everything. That's always made me a little nervous, so We typically do what's called supercharge the celiac reconstruction. This just shows at the time of operation with the head at this end, the feet down to your left, celiac, left renal vein, SMA, the portal vein with the splenic vein confluence divided. So the tumor is now held to the patient by the celiac and the hepatic. So those two are divided. The specimen is taken out. Notice, as is frequently seen, these patients are node negative. Fascinating how we're so good at sterilizing regional lymph nodes. And then you have the two ends, the hepatic and the celiac. And traditionally, the way it was done by Dr. Appleby, those two ends would just be closed. In this particular case, we did an interposition graft, which is typically what we do. And our experience will be with the Appleby and these interposition grafts will be out soon in surgery, describing this in a little bit more detail. Just another patient who had the same thing. Again, these are carefully selected patients who have had a lengthy course of induction therapy. Typically, their 19.9 has normalized. So in this case, common hepatic to celiac with an interposition graft. There was a beautiful paper published, submitted to a journal from Europe that I was asked to review, which looked at a larger series of Appleby procedures. I don't know if the audience, the authors may be in the room, but they made the point that if the left gastric artery is intact, gastric emptying is improved, with the hypothesis that it actually is some degree of ischemic gastropathy following a Appleby or extensive distal pancreatectomy that gives you poor gastric emptying. So I thought it was a great paper, a novel observation. I said, publish it, and apparently it got sent to one mean, nasty reviewer who didn't think so. So I don't think that paper has gotten published. Hopefully it will get sent to another journal. It really, I thought, was a seminal contribution. Do I have time for one last case? Because this was the last operation I did in Houston before I left. And I think if you understand the concepts of this procedure, I think that it really describes everything related to blood vessels and pancreas surgery. 13-year-old girl who developed pain after a basketball game, and she was found to have left-sided portal hypertension. As you would expect, a 13-year-old girl, this is a pseudopapillary tumor. There's really nothing else it could be. She'd even be young for an islet cell tumor, and she was thought to need a combined Whipple liver transplant, so was sent over for an opinion. So this is her right portal vein. You can see the cavernous transformation of the portal vein, really quite dramatic. Here is the left portal vein. Most importantly, she had a common trunk to her portal vein, so I don't think she needs a liver transplant. By the same token, you don't want to even go near that porta hepatis without removing all portal flow to the liver. I mean, obviously, if you got into one of those veins, it would be a very bad day in the operating room. Her portal vein is then occluded by the tumor. You can see a fairly big tumor that extends down to the SMV splenic confluence, where the SMV is then patent. So what we did in her was we simply divided her splenic vein and brought it down to her left renal vein, and then did a mesocaval shunt. So the SMV flow was going into the IVC, splenic vein into the left renal vein, and all portal flow was diverted from the liver. Obviously, it was hard to take a picture with the tumor in, but this shows the temporary mesocaval shunt, SMV, internal jugular vein graft into IVC, and then her splenic vein was into her left renal vein. We could then complete the operation. Her portal vein was just stapled across. And then the internal jugular vein was disconnected from the IVC and brought up to her portal vein, thereby restoring relatively normal anatomy with the distal splenorenal shunt still intact. This technique has been applied now to a number of patients with big islet cell tumors. Just to show you the magnitude of what can be done, some of these patients with large islet cell tumors actually do well. For some reason, their tumors do not metastasize. This man is now 2 to 3 years out from his surgery, but the same exact thing. A temporary mesocaval shunt. In his case, we needed to do a total pancreatectomy. So we embolized his splenic artery the night before operation, as it would be hard to get to. and then temporary mesocable shunt, reconnected the internal jugular vein back to his portal vein. So I think I'll stop there, leave you with my last slide, which shows our current clinical trial, which is molecular-based targeted therapy for patients with pancreas cancer who receive neoadjuvant therapy based on the molecular profile of their tumor. And I'd also like to acknowledge all my partners in the pancreas program in Milwaukee, and please encourage anyone who has reason to go to Chicago, which is, you know, an okay city. The nicest thing about Chicago is it's near Milwaukee, but you can quickly take the train, and we would love to have you visit. So thank you all very much.
Thank you very much.